The lidERA trial is the first phase 3 trial of an oral SERD to read out in early stage breast cancer. It is a randomized trial of Giredestrant given for 5 years compared to standard of care endocrine therapy, which could be tamoxifen or the aromatase inhibitors, anastrozole, letrozole, or exemestane. Patients selected for this trial were selected by risk. It included no positive patients, but also no negative patients if they had additional risk factors, including for tumors larger than 1 centimeter, grade 3, high genomic score, or high Ki67. For ASCO 2026, we presented updated data on the menopausal status. We have previously demonstrated with just under 3 years of follow-up that the addition, that giving Giredestrant instead of standard of care endocrine therapy significantly and in a meaningful way improves the invasive disease-free survival with a hazard ratio of 0.7. We had also shown that distant recurrence-free interval was improved with a hazard ratio of 0.69. Here we have focused on menopausal status. 41% of patients in the overall trial were premenopausal, about 59% of patients were postmenopausal. In the premenopausal group, the majority of patients in the control arm received aromatase inhibitors, 2/3 of patients, about 1/3 of patients received tamoxifen. Again, 69% of those patients on tamoxifen received ovarian function suppression. It was a very small percentage of patients who had tamoxifen alone. Comparing the two groups, in the premenopausal setting, standard of care endocrine therapy or Giredestrant was well balanced. Equally in the postmenopausal patients, well balanced between risk factors. But if you look at tamoxifen versus aromatase inhibitors in the premenopausal group, we saw slightly fewer patients with a higher risk features. And that makes sense clinically because clinicians would only choose tamoxifen normally in patients with a slightly more favorable prognosis. Now, if you look at the outcome for IDFS, they were consistent in the pre- and postmenopausal group. The hazard ratio for premenopausal patients was 0.65. For postmenopausal patients was 0.74. And the delta at about 3 years in the rates is about 3%. If you look at the distant recurrence-free interval, again, consistent benefit in the pre- and postmenopausal group. And we see a hazard ratio of 0.56 in the premenopausal group compared to 0.76 in the postmenopausal group. If you zoom in a little bit on the different treatments in the premenopausal group, we see a relatively similar benefit of Giredestrant regardless of whether patients receive aromatase inhibitors or tamoxifen. That's really reassuring to see. If we look at the safety profile seemed very comparable in the premenopausal group and the postmenopausal group. The dominant side effects were joint aches and hot flushes. But we also saw that patients treated with Giredestrant had fewer switches to other endocrine therapy. With standard endocrine therapy, about 10% of patients decided to switch to an alternative therapy, whereas only about 5% of patients on Giredestrant switched to an alternative endocrine therapy. Equally, fewer patients discontinued hormone therapy, about 5% of patients with Giredestrant compared to 8% of patients with aromatase inhibitors. The dominant factor for changes seems to have been in this trial musculoskeletal pain, joint aches. And if you look at we zoomed in a little bit more on that. If you look at all grades, that looked relatively comparable between Giredestrant and standard of care endocrine therapy. But really interesting, if you look at the discontinuation rates due to musculoskeletal pain, that was about 3 times higher with aromatase inhibitors compared to Giredestrant. With Giredestrant, about 1.5% of patients stopped the treatment because of musculoskeletal pain. About 5% of patients with aromatase inhibitors stopped the treatment because of musculoskeletal pain. So in summary, at ASCO, we presented updated data that patients benefit regardless of the menopausal status in terms of IDFS and in terms of distant recurrence-free survival. The safety profile is well established now both in the pre- and postmenopausal group, with advantages for Giredestrant in terms of treatment discontinuations compared to standard of care endocrine therapy.